Aseem podcast.
First of all, I just want to thank, in particular, thank both Keith and Tom for making this happen. Without them, this meeting wouldn't be taking place, and we wouldn't have really that kind of opportunity that we've got today to really get the information, the most important information out there that really tries to make sense of why we've got to this situation where we've got this epidemic of chronic disease, in particular type 2 diabetes. And over the next 30 minutes or so, I'm going to try and explain some concepts and also discuss the evidence behind how we can reverse this epidemic. So a little bit of background about me. I'm a consultant cardiologist. Some people ask, why is a cardiologist interested in type 2 diabetes? It's probably one of the most important risk factors for heart disease, and I'll explain in my talk a lot further as to why we need to focus on what's really at the root of this problem and how this will also combat not just heart disease, but many chronic diseases that exist, not just in the UK, but globally today. So my background as a consultant cardiologist, I started as an interventional cardiologist, essentially doing keyhole heart surgery and putting stents into people, and realized more and more pressure was going on the system. I've been a qualified doctor now for over 18 years, and about 8-9 years ago, I felt and predicted that unless we got on top of this burden of chronic disease through prevention, that our healthcare system is going to collapse, and essentially we're already there. I think our healthcare system is now not functioning the way that it should, but we can do something about that. I'm also a professor of evidence-based medicine, and I've done a lot of work with the medical royal colleges in this particular area. So I want to start with just a quote from the late, great Stephen Hawking, where he says, the greatest enemy of knowledge is not ignorance, is the illusion of knowledge. Now, as a doctor, as a clinician, I want to practice evidence-based medicine. But what does that mean? The founding father of the evidence-based medicine movement, Professor David Sackett, incorporates 3 particular areas or facets into this evidence-based medicine concept for the purpose of improving patient outcomes. That's what we're here for as doctors, as healthcare practitioners, as public as patients. That's what we want. We want to improve outcomes for patients. But we use individual clinical expertise, our experience as practitioners or doctors, the best available clinical evidence, and taking into consideration, most importantly, patients' values and expectations and preferences. Now, as a concept, if there is an issue with best available clinical evidence and we're not taking patient values and expectations into consideration, we are not going to get improved patient outcomes. And that is why we have this problem. That is why we have this healthcare crisis, because evidence-based medicine, unfortunately, has been hijacked by commercial influence to the extent where one very eminent professor in Stanford suggests less than 10% of clinical research studies are actually high quality and reliable. So we've got biased information, poor quality information to make clinical decisions, and if we don't use all the information we've got, we're not going to be able to give patients choices that are suitable to them. And if they don't have choices that are suitable to their preferences, whatever we give them, whether it's a drug or a lifestyle intervention, a prescription, it's not going to work. So I just want to start with that overall concept. What else did David Sackett say? He said half of what you learn in medical school will turn out to be either outdated or dead wrong within 5 years of your graduation. The trouble is nobody can tell you which half, so you have to learn on your own. And sadly, many doctors, including myself for many years, didn't really adopt or think about that concept. We took a lot of stuff as gospel truth that we learned in medical school, but science evolved, medical science evolves, and we have to now give information with the up-to-date totality of the evidence. So we have this epidemic of misinformed doctors, misinformed patients leading to chronic ill health, and there are 7 sins or specific root causes at the heart of this. So this is biased funding of research that's funded because it's likely to be profitable, not beneficial for patients, biased reporting in medical journals, biased patient pamphlets, biased reporting in the media, which I'll come on to later, which is a big problem, commercial conflicts of interest, defensive medicine, and medical curricula that fail to teach doctors how to comprehend and communicate health statistics. So this just gives an overview before we get into really the nitty-gritty of this discussion. So we've got this big problem now. We've got this obesity crisis in the UK. 60% of adults are overweight or obese. The trend suggests it's getting worse. 1 in 3 children, by the time they leave primary school, are also in the same category. Obesity alone is costing the NHS close to £6 billion. and this is set to increase to 10 billion by 2050. However, the bigger issue is type 2 diabetes. And type 2 diabetes costs both the NHS and the economy due to lost productivity. The combined cost of that is now £20 billion. And unless we curb it, unless we fail to act and intervene properly on a population level, that will hit 40 billion by 2040. And what's the root cause of this problem? Very few people would disagree that ultimately the problem on a population level is the food environment. It has become almost impossible to avoid sugary, processed carbohydrate, fattening foods wherever we go, whether it's at the petrol station, whether it's at the gym, in health clubs. It's clearly there on the high street. For me, the biggest scandal, and where I really started my journey on trying to uncover the problems we've got with dietary advice and incorrect policies that don't tackle this problem, is the biggest scandal is we even allowed our hospitals to become a branding opportunity for the junk food industry. You know, what you see on the high street, you get in hospitals. And, you know, 50% of NHS employees are now overweight or obese. 50% of 1.4 million staff, and this includes doctors to the same levels as nurses, as non-clinical staff, are overweight or obese. Now, clearly, either the information is wrong, and that might be a point, but actually, more importantly, education is ineffective when the food environment is working against you. And that's why whatever we do in terms of advice, and for individuals, which is really good, on a population level, we're not going to solve this problem unless we get policymakers to ensure that our food environment is also healthy. We shift the balance to healthier foods, and that will actually have the biggest impact. Okay, so again, putting things in context, where does diet fit into this? Now, some people will argue on the exact numbers, but essentially, few people will be able to debate the fact that when we look at chronic disease globally, poor diet now is a bigger contributor to premature death and disease than physical inactivity, smoking, and alcohol combined. So in terms of focus, in terms of the hierarchy of effectiveness, diet has to be at the forefront of policy change and also to improve individual people's health. And this is Tom Friedman's health impact pyramid. I don't think you can probably see all this at the back, but essentially what this shows is that changing the context, making people's choice the healthier choice, will have a much bigger impact than counselling, individual counselling or education. We've got very good evidence over the years from public health successes, whether it's fluoridization of water, but more importantly, as a cardiologist, I'll say the biggest impact has reduced cardiovascular death rates in the last 3 or 4 decades has been actually reduction in smoking prevalence. And that didn't come from education. Education was clearly important, but it was actually policy changes that targeted the affordability, the acceptability, and the availability of cigarettes. So this is taxing cigarettes, making more expensive. I've had patients come to me who've had heart attacks, have come back in, have you stopped smoking, Mr. Smith? Actually, doc, I can't afford it anymore, but I'm happier because of it. It's helped me stop smoking. The taxes on cigarettes probably had, probably the biggest impact on reducing smoking prevalence. Smoke-free buildings. We know when public smoking ban came in, within a very short space of time, we saw reduction in hospital admissions for heart attacks. In Scotland, it was 17% absolute reduction in admissions for heart attacks because of the fact that heart attacks and the dynamic process that leads to them actually can be quite a rapid process, but changing lifestyle can also reduce that risk significantly in a short space of time. So the effectiveness hierarchy shows that policy-based interventions tend to be more effective because they reach all parts of the population and are not dependent on a sustained individual response. So we've got sugary drinks tax, which is fantastic, and a really good start, but we need to expand that. We need to ban junk food advertising. We need to do other things that are going to help curb this imbalance we have of consumption of unhealthy foods. So we're here primarily to talk about type 2 diabetes. Now, when I was in medical school, I learnt, going back to how things evolve and the science evolves, I learned that this was a chronic, irreversible condition. We manage it with medications. We know it's a big problem. Type 2 diabetes isn't just about the health costs, it's the impact on individual people's quality of life. So our average life expectancy for someone with type 2 diabetes is reduced by 5 to 15 years. It significantly increases the risk of heart attack, stroke, kidney disease, nerve disease, blindness. We know that. But interestingly, what many people don't know is that up to 50% of people with type 2 diabetes, in a very large survey carried out in the University of California, San Francisco, up to 50% of people with type 2 diabetes experience depression, chronic pain, and poor sleep to levels at the same levels of people with terminal cancer. So this interferes with the quality of life. What else do we know about type 2? The drugs that we spend on type 2 diabetes, a big chunk of our healthcare budget, almost 10% is spent of the drug budget is on type 2 diabetes medications. Now, these medications will reduce your glucose. Great. They will marginally reduce your risk of complications, microvascular complications, kidney disease, eye disease, nerve disease. They do not reduce cardiovascular death rates. They do not prolong your life. So it's important that we share that information with patients because there are alternatives that can get them off the medications, that can improve their quality of life through lifestyle changes. And we know now that it is reversible. A lot of work, Roy Taylor has, and I'll talk about the direct study later, has been a pioneer of really getting some of that information out there, but we also have good data on low carb. So let's talk a little bit about low carb. I think two of the sort of biggest organizations that have done a lot of work in the UK, we have diabetes.co.uk, and they have a digital online program. This is essentially just advice, 10-week program, and they've got very good data showing significant remission of type 2 diabetes. The published data they have shows about 26% in all comers, and that's relevant because some of the data I'm going to show you later on, which shows higher levels of diabetes remission, specifically and almost exclusively concentrates on people with obesity. But type 2 diabetes prevalence has increased the same amount in people who have a normal BMI as people with obesity. So just tackling obesity alone we're missing a trick here. So diabetes.co.uk have shown very good results. Verta Health have shown also very good results from something similar in the United States, 60% remission rates in type 2. Again, most of the people enrolled in their particular study were obese as well. But again, this is very interesting. And this is purely from following a low carbohydrate approach, cutting out the starchy carbohydrates, just essentially advice with a bit of support from healthcare professionals. But also there's clearly medication reduction, there's improvements in cholesterol profile, there's improvements in blood pressure as well. Now, just good to see David Unwin just popped here at the back, and he's very kindly shared some of his slides with me today that I'm going to show you, but he's done some really pioneering work in general practice. And David's own work shows 47% in his patients who adopt a low carbohydrate approach have remission over about 21 months. But you can't see this at the back, but essentially I put up also what's happened to people's cholesterol profiles. Blood pressure has improved significantly. Their cholesterol profile has improved significantly because the root cause of this problem is insulin resistance, which I will talk about in detail in a minute, but it's linked to blood pressure and a cholesterol profile that increases your risk of heart attack. So this is fantastic. He's improved his drug budget, he's reduced his costs for diabetes care more than any other practice in the country, and he needs to be congratulated on that, and he's done it just from giving advice. It's not an expensive way. It's what I do with my patients, my cardiac patients as well. And David's, this one very useful slide that he gave me as well also, which is useful for patients to understand, is how different foods, in particular starchy carbohydrates, impact on blood glucose. So in terms of teaspoons, we have something like basmati rice that will, and this is in normoglycemic patients, these are people without type 2 diabetes, it will have a blood glucose response equivalent to about 10.1, a normal serving, 10.1 teaspoons of sugar. And obviously that's something that can be quite useful for patients to understand when they, especially with people with type 2, then they realize actually why the importance of cutting out these specific foods. At the bottom of the list, the kind of foods that have literally no impact or minimal impact on blood glucose are foods like broccoli and eggs. Other foods such as chicken, fish, oily fish, mushrooms, cheese. These are nice, enjoyable foods for a lot of people, and they have minimal or no impact on blood glucose. So clearly quite useful, helpful information here on this slide. And also what is good is that this has now been approved by the Royal College of General Practitioners, again thanks to David, to make sure that there is a module for GPs, takes 30 minutes. Every GP really should do this module, and they will then be able to safely prescribe and understand how they can prescribe this to their patients and improve their health. At the moment, this is not compulsory, and I think that's a problem because the data is very strong, and in my view now, without general practitioners not offering this to patients, we've got this alternative low-calorie approach, which I'll talk about later. In my view, not offering this to patients, given the wealth of data that is safe and effective, is entirely unethical. It is entirely unethical to not offer this to patients with type 2 diabetes. Now, people may, call me out or other people out saying we've got cherry-picked data, what does the overall totality of evidence tell us? What about low-fat approach? And that's a very good question, because you can actually, and we know this from low calorie, you can improve glucose control and metabolic markers from going low-fat. With a low-fat healthy diet, not your typical ultra-processed low-fat diet, which is what a lot of people, if not most people in this country are following, but we have a systematic review done by two very eminent Cochrane researchers and a professor of diabetes in the Netherlands, and they use something called grade assessments to look at the quality of data on randomized controlled trials. And what they found when you compare low fat, less than 30% of calories from fat, which is our dietary advice essentially, versus a low carb approach, interestingly, they allowed carbohydrates up to 40% of calories, which a lot of low carb advocates would say was too high, but even up to 40% of calories from low carb showed a significant superiority with a low carb approach versus low fat. In 1 year, it was significantly better for glucose control, cholesterol profile, blood pressure, less significant at 2 years, but still more beneficial. So clearly, when you look at the weight of the evidence, low carb is still the winner. It's still the winner looking at the totality of the evidence. Lever Health have done some interesting, and collected some very interesting data. So what do patients think? What do patients want? Maybe patients don't want a lifestyle change. Maybe they want to carry on with the drugs. But actually that isn't the case. And this survey of about 2,000 patients, and also healthcare practitioners, about 100 plus healthcare practitioners, revealed that only 15% of patients would prefer to carry on just with drugs to control their type 2 diabetes. The overwhelming majority wanted a combination. They were happy with a combination of drugs and lifestyle, and many just wanted lifestyle alone. But clearly, that's what patient wants. Remember the first slide, patient values and expectations. Are we as practitioners offering that choice to our patients? Say there is another approach here, and if we're not doing it, then we're not practicing. It's very clear we're not practicing evidence-based medicine. But of course, that's what we want to do. Now, there is a problem, though. There is a problem. On January the 10th this year, front page of the Guardian newspaper, front page, headline story, and it was also picked up by the BBC, blow to low-carb diets as landmark study finds high fiber cuts heart disease risk. Is it game over for low-carb? Is it? Where did this come from? So there was a paper published in The Lancet, and it was a very interesting observational study. I'm not doubting its findings. Of course, there are problems with observational studies, but it seemed to be high quality, and they showed a very strong correlation with high consumption of fiber and reduction in heart attacks and death rates, etc. And I think that's obviously an interesting finding. And what the review found is that we should be eating at least, and this is crucial, 25 grams to 29 grams of fiber a day, with indications that over 30 grams is even better, so quite high for a lot of people. Most people in the world manage less than 20 grams. Okay? This was not a study specifically addressing low carb. So where did this headline on the front page of The Guardian come from? Well, it came from one of the authors on the paper, Professor Jim Mann, who is also an advisor to the World Health Organization and an eminent researcher in nutrition science from New Zealand. And Jim Mann said to Sarah Bosley in The Guardian, that's why the headline came about blow to low-carb diets, he said, it was very difficult to have high levels of fiber on a low-carbohydrate diet unless you took fiber supplements, said Mann. And there isn't the huge body of evidence that we're talking about for supplements, he may be right about that, being beneficial. He said, adding that, it's pretty well impossible. Professor Jim Mann, said it's pretty well impossible to get enough fiber from fruit and vegetables alone. Is he correct? Absolutely not. And this is a really good example, I'll tell you why, of eminence and ignorance at the highest levels of academia trumping the truth and the totality of evidence. And I'll tell you why, because, and before I tell you why, this was also, sadly, picked up, and I actually made a complaint to the BBC, because I was alerted to this on Facebook, because I wasn't very happy with, because I knew this was nonsense, I knew this was wrong, and unfortunately Sarah Bosley in the article hadn't seemed to have got any, somebody from the low carbohydrate, sort of any scientist to really refute what was said. It was a very one-sided article. And the BBC News said, the next time someone starts getting preachy about eating less carbs, show them this. And there was a smile and a wink. And again, it was the same story, suggesting that high fiber basically means you can't get that from low carb. So I was a little bit, well, this, and there's a lot of people then jumping on, oh, it's the end of low carb, blah, blah, blah. Again, completely false. Karen Zinn, PhD dietitian in New Zealand, actually had published a paper in BMJ Open in 2017, very specifically addressing some myths out there about low carb, about its nutrient content, and even went into fiber. And she showed actually two typical, albeit well-planned low-carb meal plans, but this is in this space, what David prescribes, what's prescribed by diabetes.co.uk, Virta Health, what I prescribe, is essentially this sort of diet plan, which does include plenty of whole fruit and vegetables, maybe more vegetables and fruit, nuts and seeds, all that kind of stuff. Now, what was the average fiber intake in these two meals, typical well-planned meals? 38 grams and 45 grams. There were no supplements involved. So Professor Jim Mann is utterly wrong, and unfortunately this sort of story contributes to an epidemic of misinformation. So what did Karen Zinn conclude? We also demonstrate that the average intakes for fiber are surpassed, so it's actually not even close, it's much higher than what people are eating in all of these meal plans, and while devoid of whole grains, fiber, both soluble and insoluble, can be easily derived from fruit, vegetables, nuts and seeds. So I very much hope if anyone from the BBC or Guardian say, and listen, I've got no issue with the BBC or the Guardian, I'm actually quite proud to have been a big contributor to a lot of their work. I've written 19 opinion editorials for the Guardian, 3 front page commentaries for the Observer, I've done work with the BBC, but this sort of journalism, unfortunately, and it's not the journalist's fault, it's actually, to be honest, the researcher's fault, does actually more harm than good. Now, let's move on a little bit here. I talked about obesity not being the major issue, and certainly isn't the major issue for type 2 diabetes. It's a marker of a much bigger problem. Chronic metabolic disease starts well before people even become overweight. And it may vary by ethnicity, but we're talking up to 40% of people who have a normal BMI will have metabolic abnormalities that are linked to the same diseases that we get with obesity. And in fact, this paper is very interesting, and it's open access, and if you're interested in the next frontier where we now need to push the science further, which will help more people in the population, we have this epidemic of overfat is a condition that describes overfat adults. And really, overfat is excess body fat that can impair health, in very basic terms. And what's really interesting is that this paper reveals that actually up to 50% of people with a normal BMI will have excess body fat, in particular visceral fat, that will link them to chronic diseases. Now, the estimates from here are really quite staggering. In developed countries, in the US, New Zealand, Iceland, in the UK, 80 to 90% of adults now have excess body fat that is linked to chronic disease. 80 to 90% of adults in the UK have already got excess body fat. And this slide, again, you won't be able to see at the back, but essentially it shows that really neuroendocrine cardiometabolic stress affecting the brain, what encourages us to consume more. Obviously, there are other factors like stress, for example, and lack of activity, but the diet-induced, this vicious cycle increases excess body fat, and this causes insulin resistance and chronic inflammation. You link those together, you've then got this, really this, you're creating this time bomb of chronic disease, which includes cardiovascular disease, but also things like osteoarthritis, polycystic ovaries, gallbladder disease, non-alcoholic fatty liver disease, as well as obviously type 2. So it's not just type 2 diabetes. If we concentrate on the root cause of these, of attacking type 2, we'll also very likely cause significant impact on many other chronic diseases, and that's before people even become overweight. Now, a very useful, how do people going to be wondering, well, how do we measure excess body fat? There are very kind of high-tech scans you can do, like DEXA scans, and what they can do is show excess body fat, but actually a very simple way is to look at your waist to height ratio, and your waist should be less than half your height. And if your waist is less than half of your height in circumference, then that's actually a good rule of thumb. Okay, we'll move on quickly. Okay, we're almost there, right? Briefly about Piopi diet. So this is a village in southern Italy. I wrote a book about it with my co-author, Donald O'Neill, former international athlete. And we went to Piopi, which is one of the world's healthiest villages. Also, interestingly, has a historical link because Ancel Keys, the American scientist that really was at the forefront of pushing the low-fat food movement, spent a lot of time in this village looking at the habits of these people, but he just loved living there because it was just a very idyllic place. And this book was written to bust many myths that are prevalent today, including why saturated fat isn't a problem. This editorial I wrote with Rita Redberg and Pascal Meyer, both eminent cardiologists, editors of medical journals, practicing cardiologists that see patients, was very clear after collaborating with them for many months that we decided the evidence suggests that saturated fat does not cause heart disease, and we really should be focusing on more important things, in particular insulin resistance and chronic inflammation, and that again is linked to a diet which is high in refined carbs and sugar, and also there are what I describe as, what I promote and advocate as one very useful approach based upon all the data I've looked at is a low carbohydrate Mediterranean style diet. So taking the best components of the Mediterranean diet and combining it with stress reduction, physical activity, and smoking cessation if you're a smoker. And if you do that, you'll significantly reduce your risk of metabolic syndrome and heart disease. Patients contact me all the time through social media about how they've managed to follow my kind of plan or what David's been promoting through low carb, and they're coming off their medications, they feel better, they're reversing their type 2 diabetes. Of course, when I wrote the book, I wanted to make sure it was backed by some credibility. Former Secretary of State for Health, Andy Burnham, backed the book. The chair of the Medical Royal College is arguably the most important doctor in the UK, backed the book and said every doctor and household should have the book because the science was rigorous and it reflected the totality of the evidence. I was actually the reason I put this slide up is the book became #1 international bestseller in Holland. And the reason it became a bestseller in Holland, and I could not have predicted this, is a documentary, a current affairs program contacted me, and they decided to put 3 sort of relatively random people with metabolic disease on my diet just for 21 days. I say dietary changes can affect people very rapidly. That's key, that's important. That it doesn't take months and years, it can happen within a few weeks. And what happened really for these 3 patients, one chap with heart disease and high blood pressure and type 2, another one with type 2 and a lady with obesity, is in 21 days, and they're hugging here because they were told their blood results 21 days after the diet, which was being filmed at that point live for the recording. The chap with type 2 came off all his drugs and got his type 2 into remission in 21 days. The same thing happened for the guy with high blood pressure and type 2. They were very emotional. This stuff works. Okay, we can argue long term, but it works certainly in the short term. But there's a problem, and this is the problem we've got today, is that we have attacks going on. We have people who come out with misinformation, as I've highlighted earlier. The British Dietetic Association, who are a respected body, they came out and said the Piopi diet is one of 5 celebrity diets to avoid in 2018. And if they had a legitimate argument, I would be happy to debate with them, but they didn't. They used factually incorrect statements. Sean Porter, who I later found out was consultant dietitian to the British Fruit Juice Association, which wasn't mentioned on BBC News, said that we were arguing a high level of saturated fat consumption. Completely false. That wasn't in the book. She also said we cherry-picked data. We didn't. We used systematic reviews and those that use a totality of evidence. Actually, what was going on, in my view, is the British Dietetic Association have probably been cherry-picking data. And I saw this great tweet from John Cleese, which I thought was quite interesting and kind of maybe applies to this. One should never forget the principle of the first principle of the old KGB: always accuse your enemy of exactly what you are doing. Now, I wouldn't expect that from the British Dietetic Association, but then we also have Public Health England. And after the Piopi diet, after Tom Watson came out saying the Piopi diet helped him, along with reading Michael Mosey's book, lose 7 stone in 1 year, I was getting invited to give talks, speaking at my local hospital, and the chief executive of Public Health England, Duncan Selby, rang the chief executive of Tameside Hospital essentially to not give me a platform to in any way endorse this Piopi diet, and in a way stop. And the chief executive got a phone call. They also contacted Andy Burnham, the mayor of Manchester, to try and get him to dissociate himself from the book, really threatening him with negative press. Luckily, these people stood firm. The chair of the Medical Royal College was also contacted. This is really, this is ridiculous. We need to have a open scientific debate here. But this actually doesn't do them any favours. And I think Zoe will show later on in her talk why Public Health England may have a problem with this sort of dietary plan. Okay, so half of our diet is now ultra-processed food. That is a major issue. Very quickly, I know we've not got much time. Kevin Hall also, so very quickly, most of our diet from ultra-processed food is coming from starch and sugary products. Those food groups in the BMJ show starch and sugary products, ultra-processed carbohydrates. Kevin Hall recently did a study comparing equal calories of non-processed versus ultra-processed food and found within 2 weeks the average calorie consumption went down by 500 in people who had non-processed food. So there's something about the hyperpalatability of these types of foods that drive overconsumption. And really, if we get ultra-processed food down, which is now 50% of the diet, very simply 5 or more ingredients industrially produced comes out of the packet. That's what I tell patients. It's ultra-processed. Try and avoid it. Then I think on a population level we'll do very well. We have the Lancet study showing the so we've got the low-calorie shake, 800 calories a day, showing some good results, 47% remission at type 2 diabetes in a year. Great. Question is, how many people actually who were enrolled took part in it? That's an important question about working, but clearly the people that took part, it worked. But the problem we have is this, in my view, is that these are the ingredients that go in. Mike Lean, one of the authors, said to me, "It's not the exact thing, but he said it's very similar what they used, a kind of low-calorie shake. We have all these ingredients, whey protein, inulin, refined soy oil, hydrolyzed maize protein, flavoring." I have a bit of an issue with this. We're getting a concept across of using an ultra-processed, low-calorie shake to beat type 2 diabetes. At the same time, on a population level, we want people to eat real food. Fine, give them the option. So modern bread today, ultra-processed. Go in the supermarket, wholemeal bread, it comes under the criteria of ultra-processed. Starchy carbohydrates, big proportion on the Eat Well guide. A lot of people are going to buy bread that's ultra-processed. There is a problem there in my view. So I just asked a question on Twitter. Some people may say it's a bias. It's not very high-quality evidence. But just to make the point about how many people would choose between a low-calorie shake for type 2 diabetes versus cutting out the carbohydrates and eating real food. And in 24 hours, I got 3,643 votes. 96% went real food low carb, 4% low calorie shake. Now, it may be low calorie shake works for some people. I'm not arguing that, and that may be what they want to choose. I'm just making the point, we need to offer patients this as well. If we're not doing this across general practice in the UK, we are not in keeping with evidence-based medicine, and we are also not being ethical. Right, I will just finish on my final slide. We have a problem, obviously, with getting this information out. The science alone is not sufficient. We've got to overcome vested interests. Simon Chapman, who did a lot of work on smoking reduction in Australia, gives a very interesting take on his lessons in public health advocacy. One of the things he says is, finally, unless you're an advocate for an utterly uncontroversial policy, soon as your work threatens an industry or ideological cabal, you will be attacked, sometimes unrelentingly and viciously. That's from Simon Chapman. I think we just need to be aware of that. A lot of people in this space have been victims of this, including myself. And ultimately, this is about transparency. It's about getting the information out. It's really about democracy and democratization of science. And John Adams, the second president of the US, says the preservation of the means of knowledge amongst the lowest ranks is of more importance to the public than all the property of all the rich men in the country. If we get the information out, if we use the science, if we use that to influence policy, then in 3 years from now, this should be the front page of the Daily Telegraph, UK reverses obesity epidemic. Thank you very much.
Thank you very much, Aseem. Thank you.